Ureteral stents are very commonly used in urology. We use them almost every day, and we need them in many facets of urology. One of the problems is incrustation. It really limits the amount of time we can leave a stent in. Studies show that the longer you leave a stent in, the more likely it is to encrust. I have seen incrustation form within about 2 weeks, however. So it's just variable depending on the patient and their urine and the different types of environment that they're in.
Urine is a very complex medium. It contains all kinds of components. Calcium oxalate crystals, calcium phosphate crystals, and so on and so forth form. Now, the crystals don't really care whether, what surface they attach to, whether it's a biomaterial, whether it's a tissue, such as the ureter. They'll just attach to anything they can attach to. Incrustation can form both on the outer surface of the stent or in the inner lumen of the stent. There's no way to predict whether a patient will encrust significant enough for it to have a clinical problem.
And if a stent gets encrusted, it can actually be quite difficult, both for the urologist and the patient, in order to deal with this. It causes irritation when patients have to void all the time, and then when they do void, they get flank pain because of the reflux from the stent. Stents get colonized with bacteria and biofilms. They cause infection, which then limit the length of time you can actually use them. There's been case reports and series showing that when you've had a stent in for a long time, your kidney can actually be irreversibly damaged. It can take anywhere between 1 to 3 surgeries to remove it. Often at least a percutaneous nephrolithotomy, a cystolithopaxy, plus or minus a ureteroscopy. So we have to balance this management of decreasing the symptoms and having the patient resolve this versus leaving it in too long where the stent will become encrusted.
Given the significant role of ureteral stents in patient treatment and the significant complications associated with them, there is a need for us to put more research effort into improving their functionality, because ultimately that will result in better patient care. So incrustation can form in a couple of different ways. One is through direct interaction between the crystals and the material itself. And the other one is facilitated through the attachment of what we call the conditioning film, because shortly after you insert any biomaterial into the urinary tract, urinary components start to deposit on the surface and form this conditioning film layer. Well, this layer consists of many different types of proteins and ions and so on. So that interaction becomes very, very complex. And then that can happen in one of two ways. One is in the case of calcium oxalate crystals, you have to have higher concentration of calcium and oxalate. A different type of incrustation is bacterial induced, and those are struvite crystals or magnesium ammonium phosphate. And those form only in the presence of bacteria that produce an enzyme called urease. So for calcium oxalate based incrustation, the sequence of events tends to be that the stent gets placed, gets bathed in urine. Urine components such as proteins and other compounds start attaching to the surface. Crystals that are already present within the urine due to the supersaturated medium will begin to interact with conditioning film components and bind to them. In areas where there's no conditioning film, the crystals will physically begin to interact with the surface itself and attach. And so you have these little areas of incrustation here and there, and what happens over time is that those little groups of crystals become a nidus for further growth, because those crystals are bathed in the urine, and that facilitates growth of the crystals and incrustation across the entire surface of the stent. Now, when we're talking about struvite-based incrustation, that process is different because that's completely bacterial driven. So what happens there is that the device gets placed, bacteria that are planktonic or swimming in the urine will begin to attach to the surface. They form little microcolonies because the attached bacteria begin to divide. Once that happens, the bacteria then begin to produce what is called an exopolysaccharide, and it's basically a sugar coating, if you will, that is a protective coating. Now, because these bacteria produce urease, which breaks down urea and significantly increases the pH of the urine, magnesium and ammonium and phosphate begin to interact with each other and form crystals. Now, this happens within the biofilm. And so what you tend to get is a layer of bacteria covered by crystals. And again, now you have the crystals there that then become a nidus for further bacterial attachment and crystal growth. If you look at surfaces that have crystals or other components attached to them, quite often you'll find little nooks and crannies and crevices that are part of the material. So what tends to happen is that components just get stuck in these nooks and crannies or crevices and just accumulate over time.
There's various properties to a urinary material surface that will basically make it more likely to encrust versus less likely to encrust.
While the Tria stent does not prevent encrustations, it does help control the accumulation of both urine calcium and magnesium salt deposits, both in the presence and absence of bacteria in vitro settings. The Tria ureteral stent is designed to have low surface energy on both the inner and outer surfaces. Materials with higher surface energies electrostatically attract and retain molecules on the surface of the device, causing them to spread out in a thin layer. Lower surface energy materials make adhesion and adsorption of these molecules much more difficult. You can see this typified by the low surface energy of a freshly waxed car, where water beads up and rolls off the surface. Surface energy can be indirectly measured by the angle formed between a drop of water and the surface that the drop sits on. This is called the contact angle. A high contact angle means a low surface energy, similar to the water beating up on a waxed surface. A low contact angle means a high surface energy, where the drop wants to spread out on the surface. Tria's PercuShield surface is designed to have low surface energy to be unreactive to aqueous solutions, and in a bench study reduces the likelihood of combined magnesium and calcium salt accumulation.
We need to take it back to the basics. We need to look at biomaterials in the urinary tract, and we need to design them so that they repel things.
Dirk Lang and I here at the Stone Center have been working with various types of coatings and various types of antimicrobial peptides in order to try and reduce the amount of bacteria as well as conditioning film that attaches to the surface of stents. So with that, a layer that is less hydrophilic, that is smoother, and has a lower surface tension. So it's just not sticky overall, it's smooth, just things won't attach to it. I think with having a stent that is just less reactive to patients, that is more inert, I think is really important. And really having them reduce the amount of incrustation would be really helpful in improving those patients' lives.
Tria ureteral stent is the first and only stent to incorporate PercuShield, a proprietary surface technology engineered onto the outer and inner stent surfaces for optimal coverage against urine calcium and magnesium salt deposits.